Arrhythmogenic right ventricular cardiomyopathy. Okay, now we are doing the part 3 of the cardiology revision series of the notes. This is the second most common cause of sudden cardiac death in young. And pathophysiology is autosomal dominant with variable right ventricular myocardial, which is replaced by the fatty and fibropathy tissue. What are the clinical features? There will be palpitations, syncope, sudden cardiac death. Investigation on the ECG, you will see abnormal V1, V2, V3. There will be T wave inversions in these. Epsilon wave 50% with those who have ARV. This is best described as terminal notch QRS complex. Echocardiography changes, you will show enlarged hypokinetic right ventricle with a thin free wall. MRI shows fibrofatty tissue. Management drugs like sotalol is most widely used antiarrhythmic. You can do catheter ablation to prevent ventricular tachycardia. Implantable cardioverter defibrillator. Naxos disease, AR, variant of ARVC, triad of ARVC. Palmoplantar keratosis and woolly hair is there. Angina pectoris drug management. Okay, so syndrome X, this is angina like chest pain on exertion. There will be ST depression on stress test, and normal coronary artery on angina. How will you treat? You will give nitrates. We will see the drug management of angina pectoris. Immediately you will start, in all patients you will give aspirin and statin. Now, aspirin is meant to improve long-term prognosis as well in angina. So in all of them you will give aspirin unless it is contraindicated. Sublingual GTN to abort attacks, and then you can give beta blocker or CCB as monotherapies. CCB you will prefer verapamil and diltiazem, but if you wish to combine it with beta blocker, then you need to give it with mifedipine. Okay? Now these you can give maximum tolerated dose. These are insufficient, then you can add on nitrates, ivabradine, nicorandil and ranolazine as per the catering to the patient's needs. Now in Prince-Metal angina, there is pain at rest due to narrowing or occlusion of the proximal coronary artery due to spasm. And this can't be diagnosed on coronary angiography. So beta blockers should not be used in this form because they may worsen the coronary spasm. And patients with this condition may be treated effectively with dihydropyridine derivative CCB such as amlodipine. Now we'll see parenteral anticoagulation. Parenteral anticoagulation is fondaparinol, which activates antithrombin 3 and potentiates inhibition of coagulation factor 10A subcutaneously. Direct thrombin inhibitor, bivalirudin, this is given intravenously. Dabigatran is again a direct thrombin inhibitor, but this is given orally. Eisenmenger syndrome. Now this is a reversal of the left to right shunt, and this is a congenital heart defect due to pulmonary hypertension. Uncorrected left to right shunt leads to remodeling of the pulmonary microvasculature. There will be obstruction to the pulmonary blood flow and pulmonary hypertension. So clinical features may original murmur disappears. There will be cyanosis, clubbing, right ventricular failure, hemoptysis, and embolism. This is associated with VSD, ASD and PDA. Management, heart lung transplantation. Chest pain. Okay, how will you manage chest pain in a patient? So initially you will give glycerol trinitrate, then aspirin 300 mg. Do not give antiplatelet outside the hospital setting. Then you can give oxygen if the saturation is less than 94%. Then you perform the ECG ASAP, but do not delay hospitalization. Now the chest pain is less than 12 hours and the ECG is abnormal. You have to admit it. Emergency. 12 to 72 hours chest pain and hospital, you have to do a same day assessment. If it's more than 72 hours, full assessment with ECG and troponin should be done. Anginal pain, constricting, discomfort, front of chest, neck, shoulders, jaws, arms. This precipitates on physical exertion and it is relieved on rest or GTN within 5 minutes. Now all clinical features are there like chest pain and all, so it will be typical. If 2 are there, then atypical, 1 or non-anginal chest pain. So if stable angina cannot be excluded by clinical examination, so first line you do a coronary angiography, second you can do a non-invasive functional imaging, third you can do an invasive coronary angiography. Non-invasive functional imaging, you have myocardial perfusion scintigraphy with single photon emission CT, or there is something called a stress echo, first pass contrast enhanced magnetic resonance perfusion. Then there is MR imaging for stress induced wall motion abnormality. So all these are available as non-invasive functional imaging options for coronary for angina. We come to atrial septal defect. This is congenital heart defect found in adulthood. 50% patients are dead at around 50 years. Clinical features, there are ejection systole, murmur, fixed splitting S2, embolism passed from venous system to the left side of the heart causing stroke. Ostium secundum, 70% of ASD associated with Holt-Oram syndrome. There's triphalangeal thumbs. ECG mein there will be RBB with RAD. Ostium primum, this prevents earlier association of abnormal AV valves. ECG mein there will be RBB with left anterior LAD. Prolonged PR interval will be there. So you have to differentiate between these two in the paper. Okay, we'll read this again. Ejection systolic murmur, this comes. Fixed split S2. Embolus will pass from venous system to left side of the heart and that will cause stroke. Ostium secundum, 70%. This is associated with Holt-Oram, that is tripharyngeal limbs. Ostium secundum mein there will be RBB with RAD. Okay? The right axis deviation. Ostium primum presents very early and this is associated with abnormal atrioventricular valves. Primum is left anterior descending and isme you will see prolonged PR interval. Okay? We'll see tetralogy of Fallot. Now this is the most common cause of cyanotic congenital heart disease and this presents within 1 or 2 months and up to 6 months. So there is anterior malalignment of the aortopulmonary septum and the patient will have ventricular septal defect, right ventricular hypertrophy, right ventricular outflow obstruction and pulmonary stenosis and overriding of the aorta. So all these 4 components are part of tetralogy of Fallot. Other features, there will be cyanosis, TET spells due to right ventricular outflow, tachypnea, severe cyanosis. Typically occurs when infant is upset and pain and fever is there. Right to left shunt is there, ejection systolic murmur due to pulmonary stenosis, right-sided aortic arch, 25% patient. Chest X-ray mein you will see boot-shaped heart. Okay? ECG mein right ventricular hypertrophy will be there. Management, you will do surgical repair. There will be cyanotic spell. So you give a beta blocker in this case in tetralogy of Fallot. This will decrease the infundibular septum. Okay? We'll see long QT syndrome. So you can see the PR interval and QT interval out here. And this is the QRS complex. So between these two you have this PR interval which includes the P wave and just before the starting of the Q wave you have the PR segment. From the start of the Q till the end of the T. Okay, so that is ST segment. So how to remember these? Just remember that this is the entire ECG. Okay, the segments are going to cover the entire ECG and you're just making a cut before the Q. Okay, so you will remember the beginning and the end and the beginning and the end. Okay, so this is QRS complex. Okay, so long QT syndrome is inherited condition with delayed repolarization of ventricles. Uh, there will be ventricular tachycardia or torsades de pointis in this because of the blockage of potassium channels, and this can lead to sudden death. Now, most common cause of LQTS are the LQT1 and T2, and this is the defect in alpha subunit of slow delayed rectifier potassium channels. Normally corrected QT, decrease in the QT interval less than 430 in male and less than 450 in females is called as long QT syndrome. So the congenital causes are Jervell-Lang-Nelson. So this will have deafness due to abnormal potassium channels. Romanov-Arch syndrome, no deafness. Drugs में there will be amiodarone, sotalol, class 1 antiarrhythmic, tricyclic antidepressant, SSRI, methadone, chloroquine, terfenadine, erythromycin, haloperidol, and ondansetron. Others are hypocalcemia, kalemia, magnesium. Then you have anterior myocardial infarction, myocarditis, hypothermia, subarachnoid hemorrhage. All these are causes of long QT syndrome, which are extremely important. Now, clinical feature may be picked up on routine ECG. Long QT1 is exertional syncope. Often during swimming, the patient will have. Long QT2 is associated with syncope, emotional stress, exercise, auditory stimuli. QT3 events often occur at night or at rest. There will be sudden cardiac death in these. Management, you give a beta blocker, which is an implantable cardiac defibrillator in high risk. Cholesterol embolization, cholesterol may break off. Okay, we'll continue this in the next part. Do continue in part 4. We'll see in part 4.